Welcome to the April 2022 edition of the ASC eJournal presentation. I am Dr. Rezai, the chair of the ASC eJournal committee, and I'm very happy to introduce Dr. Bronson as our presenter for today. Dr. Bronson is currently a cytopathology fellow at Northwestern University in Chicago, and very soon he will join as faculty as an assistant professor at Northwestern University. His interest is GYN pathology, which kind of goes with this as an extension to his topic for the talk today. And when he's not very busy at work, he enjoys spending time with his two cats with very exciting names, Miso and Noodle. I think next time we would like to see them at least in the background of your presentation.
Oh, if only, wouldn't that be lovely?
Yeah, I know, that would be great. I don't know how would they allow you to talk though, but we'll figure that out later. Before starting, please, to the audience, please make sure that you send your questions through the question box, and I will monitor them. And at the last 10 minutes or so of the talk, we will have a Q&A session. So hopefully your questions are answered at that point. With that, I will turn the virtual podium to Dr. Bronson. Take it away.
All right. Thank you very much for that lovely introduction, Dr. Rezai, and my sincere thanks to the eWebinar committee for letting me come and chat with you all today. Unfortunately, yeah, of course, I don't have my cats with me. Instead, I have my co-fellow Dan Hodges here behind me. Give us a wave, Dan. There we are. Today, I'll be talking with you all about the paper here with the long title, Performance of Specific Morphologic Features in Distinguishing Low-Grade Squamous Intraepithelial Lesions from High-Grade Squamous Intraepithelial Lesions in Borderline Cases. Of note, I have nothing to disclose. So here I am, yet another picture of me. Follow me on Twitter. We had quite a nice turnout, in my opinion, for the live Twitter chat that I did yesterday, with an impressive number of audience responses to polls and questions. And I just can't recommend getting on Path Twitter and getting involved in that enough. I learn something on there almost every day. So these are my objectives for my talk today. And a fourth objective that I had in my original draft of the PowerPoint, but ultimately decided against, was to wallow in controversy, but decided that that didn't quite make the cut. So definitely we're going to talk about some controversial aspects of some of these studies that involve inter-observer concordance in gynecologic cytopathology, and see where we can go from there. And I believe at this point, we actually have a poll for the audience that I'd like everyone to take a second and complete, just to sort of give us an idea of the demographics. Let's see. Just to see who is out there, just to give me an idea. There we are. I actually can't see anything, so I just kind of trust maybe that the poll is working.
You have 33%.
And actually the results are.
Go ahead.
Go ahead. No, go ahead.
You have 33% pathologists, 1% residents, 6% fellows, 57% cytotechnologists, and 4% students.
Wonderful. Exactly the information that I was interested in hearing. I was very curious to hear who would turn out to a talk like this, especially a talk that is sort of kind of largely centered around morphology. So we're going to start the talk today with just kind of a brief case study of sorts. Just kind of indulge me on this one. So we've got a 30-year-old woman, a G0, P0, non-pregnant, who undergoes routine Pap screening with GO testing. Her previous Pap screens have been nil. She has no previous history of squamous intraepithelial lesions. And of note, on this particular Pap, HPV 16 was positive. So as we look at the next several images, I want you to think of, in this particular patient, in this particular case, what are the implications of an L-cell interpretation versus the implications of an H-cell interpretation? And further, in accordance with what the approach was taken by the authors of this paper today in terms of the requirements that they had for their own observers, I'd like for you to try to put each of these following cases into a box. Try to think in terms of, does this image represent L-cell or H-cell? So here's the first image. From our patient, the hypothetical patient, hypothetical liquid-based cervical pap finding. Here's a second image. What are your thoughts? A third image. Another potential hypothetical finding in a pap from such a patient. Final image. This one, for those of you who hung out with me yesterday on Twitter, may recognize this particular image. This is from the one of the figures from the paper itself. Okay, so hopefully that was enough time for each of you to kind of see each one of these images in the context of this hypothetical patient and to kind of come up with an interpretation. Are you thinking that this could be L-cell or it could be H-cell? And in light of that, I'd like to just kind of remind everyone that the newest American Society for Colposcopy and Clinical Pathology guidelines, the ASCP, have changed with respect to their recommendations for who receives expedited treatment. That is to say, people who would go an excision procedure like a LEEP or a cold knife cone without undergoing confirmatory biopsy first. So it's actually preferred that in non-pregnant patients who are 25 or older, such as our patient, who have an H-cell pap interpretation and are HPV 16 positive, that you can actually, it's preferred treatment to skip the biopsy and just go straight to doing an excision procedure in these people, which makes the implications of an H-cell diagnosis in this particular clinical context especially significant. Additionally, these same guidelines say that an H-cell pap interpretation in a patient who, quote, never/rarely is screened, it's preferred that these patients undergo expedited treatment. And this really casts a fairly broad net and is kind of up to the clinician to interpret what does it mean that a person is never or rarely screened, but definitely creates an even broader category of people for whom this expedited treatment could potentially be preferred and for whom an H-cell diagnosis is really especially significant. So going through these pictures that we just looked at, this is actually from the atypical chapter of the Bethesda book. This picture actually has a caption of this interpretation per Bethesda was given as ascus, but then the actual follow-up biopsy showed keratinizing H-cell, extensive keratinizing H-cell. So, is that what is necessarily represented here? It's hard to know. Obviously, this is a single still image. Is this the best representative image even from the sampled tissue of H-cell? The second picture is from the actual paper itself. And this is given as an example of possible high grade existing in a collection of cells that may represent low grade dysplasia. I think that there's even options for other possible interpretations here, despite our trying to cram it into a box. And in fact, there are probably parts of this cell cluster that may even show features that are more suggestive of kind of reactive features. So it's very tough, it's very complicated, but ultimately on follow-up biopsy, the so-called reference interpretation that was attributed to this particular case was H-cell. So there's a follow-up biopsy that was H-cell. And again, I ask, do we think that H-cell is necessarily represented in this image? That's complicated. This is another picture from the Bethesda. This is actually from the H-cell chapter of the Bethesda in the little subsection on high-grade lesion existing in a background of low-grade lesion, which is a complicated designation indeed. And we'll touch on that later. But these are kind of it's the caption was sort of suggesting that these are high-grade cells, and they do indeed show features that are not incompatible with high-grade lesions, and that sort of saying that, you know, obviously if you have some high-grade cells in the background of L-cell, that a high-grade interpretation, unequivocal H-cell should be rendered. And then this is a final picture from the actual paper that we're going to be discussing today. And this is a picture of a collection of cells that show features of dysplasia, but are keratinizing. And this is actually an especially interesting picture to me. I posted this on Twitter yesterday and asked people to do a similar exercise, cram this into a box of L-cell versus H-cell. And this received about 70 responses, nearly 70 responses as my last check on Twitter today. And it's almost split right down the line as to whether or not people think that an interpretation of H-cell or L-cell is warranted here. And indeed, cases that show keratinizing dysplasia kind of notoriously show some challenges, at least anecdotally, and that's part of what the authors wanted to explore today. So in today's journal article, the authors, in kind of the spirit of reproducibility studies in gynecologic cytopathology that have gone before it, both you know, others from other studies gone by and ones that have actually been done by this set of authors previously, they've noted that there's a subset of low-grade and high-grade, or a subset of cases in which low-grade lesions and high-grade lesions are difficult to determine, or difficult to separate from one another. So cases that have, you know, these intermediate features between low-grade and high-grade. And are there confounding features that make this distinction challenging? So the authors kind of hypothesized that in some of these cases there might be sort of a unifying set of morphologic features that these cases have in common that make these cases uniquely challenging. And that would really be kind of a useful thing to identify in clinical practice, at least in as much as we could kind of keep an eye out for, oh, this is the feature that really makes these especially tough, and kind of could clue us into that. So they wanted to figure out which features made a difference here. And further, are there any features that can help us resolve these issues? So in order to look at this, they put together kind of a small but elegant study with kind of a fairly simple methodology. So in summary, they found 21 pap slides that had concordant biopsies, and 11 of them had a concordant biopsy of L-cell, and 10 had a concordant biopsy of H-cell. They specifically picked cases of H-cell for which the biopsy interpretation was CIN3, and it was reviewed by 11 expert cytologists, admitting kind of the problematic nature of you know, what exactly does constitute an expert, but they did their best. And then they looked at the features on these slides and gave an overall interpretation on these slides to see if there were any features that corresponded with people having issues with being able to differentiate between L-cell and H-cell in this particular case collection. So in terms of the slides that they picked, these 21 slides, these were slides that were actually rejected from the PAP education program. And the PAP education program has a CAP committee that is in charge of putting these slides together. And in fact, the slides are actually largely submitted by the CAP committee members themselves. So as such, these slides were thought to be good examples of the biopsy diagnosis, but they were diagnostically indeterminate or were otherwise challenging. So these slides, in order to be qualified for the PAP education committee program, they have to have a concordant biopsy. So you do have to be able to say that, oh yeah, what I look at and see on these slides, it does correspond with what I see on the biopsy, in my opinion, or in the opinion of at least 3 of these committee pathologists. And they have to be of high quality. So they're vetted for the actual quality of the slides themselves. Are these interpretable? Are they adequately cellular, et cetera? So they picked these high quality slides with concordant biopsies, but they were otherwise deemed challenging or had some issues. And some reasons for rejection by the committee was that they had more than one diagnosis on the slide, for instance. So these slides that go to the education committee are actually ultimately used for, let's see, PT testing, or you kind of performance testing, and they said that basically for those slides you can't have more than one diagnosis on the slide. It's supposed to be representative of only a single entity. So more than one diagnosis, these slides go out the window. And then for some of them, they had a relative paucity of diagnostic cells, whatever that means. Kind of just subjectively, there were too few diagnostic cells. They thought that maybe these would be tough for people in this education program. And then also the really complicated diagnostic cells that were not clearly representative of the reference diagnosis. So that could mean any number of different things. I'm sure that any number of people out there could kind of think, well, you know, what does that mean that it's not necessarily representative? Are these cells that are indeed representative of the reference diagnosis and just don't look like it, or is the reference diagnosis not represented in the slides at all? Problematic, potentially. In terms of the evaluators that they had look at these slides, they had 11 members of this CAP cytopathology committee. They had 10 pathologists, so 1 cytotechnologist from a range of different practice settings. So they weren't actually all from the same institution or anything like that, which, as the authors point out, is actually kind of interesting, because I think, as probably all of us agree, people that are from the same institution may have this likelihood, at least anecdotally, of falling into similar practice patterns, and may be a little bit more inclined to agree with one another, just as a matter of course, as such. So each of these people, as just kind of by merit of being member of this CAP cytopathology committee, and that are people that are kind of involved in the slide selection process, have kind of at least demonstrated at least some interest and expertise in gynecologic cytopathology. And several of the members, or several of these evaluators, are actually authors of the most recent Bethesda Atlas. So they've been heavily involved in gynecologic cytopathology and have some significant amount of experience. So for each one of the slides of these 21, they called on the evaluators to estimate the number of L-cell cells, cells with dysplastic nuclei and INSEE ratios greater than 0.5, which is kind of taken as a surrogate designation for H-cell. And I'll touch on this again later. And obviously this is potentially problematic, but was used as a surrogate designation kind of to try to imply H-cell, so that it wasn't the case that they had to both count the number of H-cell cells and then kind of separately render an interpretation of H-cell. So it was kind of trying to not make it a little too on the nose or something. So then additionally, they looked at keratinized dysplastic cells. As previously stated, clusters of L-cell with potentially admixed H-cell, atypical squamous metaplasia, which was used as sort of a surrogate designation for ASCH in this paper. It's definitely at least one of the morphologic manifestations that tends to be accounted for as ASCH, as well as atypical glandular cells and the presence of inflammation or microorganisms. This is, for instance, again from their paper, as previously stated, an example of dysplastic keratinizing cells, which in accordance with the author's hypotheses is kind of been largely held, at least anecdotally, and I suspect in the experience of several people watching, to be potentially problematic in terms of being able to distinguish between L-cell and H-cell. Similarly, this is another picture from the paper, and this was supposed to be a group that had potential admixed H-cell in a background that sort of largely consisted of L-cell, at least as denoted on the caption. And these are examples of atypical squamous metaplastic cells that are, as denoted in the paper itself. So additionally, they were called to create an overall interpretation, L-cell versus H-cell, according to usual practice. And note the conspicuous absence here of any intermediate categories, and we'll touch on that again later. And as noted by the authors, it's possible that for any number of these cases, in terms of people's usual clinical practice, they may have used an intermediate category as such, but that wasn't the point of the exercise. So evaluators were actually aware that follow-up biopsy showed either L-cell or H-cell, but they weren't aware of the relative percentages of each in the entire study set. And obviously it was ultimately half and half, and people could maybe have speculated to that or have guessed that, but it was unclear if anybody was actually successfully able to do so, and people were unaware of that from the beginning. So the results showed that observers were more likely to agree with a reference diagnosis of L-cell than H-cell. So in 76% of instances, people agreed with a reference diagnosis of L-cell, and people agreed with 61% of the cases that had a reference diagnosis of H-cell. And this more or less is in accordance with previous reproducibility studies from days gone by, and we'll touch on some of those and some of the specifics of that. So there were 9 of the 21 slides that had high reproducibility. That is to say, for only 9 of the slides, more than 9 observers agreed with the reference diagnosis. And for 7 of those 9, the reference diagnosis was L-cell. So again, kind of along the lines of what was said on the previous slide, people are more likely to agree with themselves and with a reference diagnosis with respect to L-cell. And there were 6 slides for which most of the reviewers actually disagreed from this panel. And 4 of those slides from which most of the reviewers disagreed had a reference diagnosis of H-cell. So people were much less likely to agree with themselves and to agree with reference diagnosis in terms of these cases that had H-cell on biopsy. So there was the individual observer concordance with respect to the reference diagnosis ranged from 11 out of 21 to 18 out of 21. That is to say, in essence, 11 out of 21 got the diagnosis right, up to 18. So that's a pretty wide range, and obviously right is a little bit in air quotes here, but that is definitely a considerable range. And what was really notable is that there was really quite substantial variability for each of the features that were identified. And ultimately, the only factor that was found to significantly influence the interpretation of H-cell versus L-cell was the number of ASCH and or H-cell cells found, as kind of defined in the context of this study on the respective slides. And for more than half of the slides, there was quite a wide range of interpretations, even in terms of the number of H-cell cells. So for these 21 study slides, more than half in this panel of expert reviewers, people said that they had any number from 0 to greater than 20 observed H-cell cells. So there was really a wide range of interpretation of exactly how many H-cell cells there were on each one of these respective slides. So looking at previous studies that were actually done by this same group, kind of the spiritual predecessors to this particular paper, here we have L-cell versus H-cell, concordance between the interpretation of low-grade squamous cell and high-grade squamous cell lesions and Pap tests from the education program. And in this particular case, we actually had more than 100,000 responses from more than 4,000 cases. And in this considerably larger look at a similar problem, responders were much more likely to misrepresent H-cell as L-cell than the reverse. And they noted in this particular paper that cytotechnologists in particular, in this context, were more likely to undercall H-cell. There is speculation as to why, but particularly in the context of things like this education program and, let me see. Performance testing, the cytotechnologists are deemed less for undercalling H-cell than pathologists are. So they wondered if it was somehow or other related to that there might actually be an element of gamesmanship here, but the point still stands nonetheless. And then of note here also, ThinPrep L-cell was actually more likely to be misclassified as L-cell than SurePath L-cell. The significance of this is not entirely clear. So an additional paper from a little bit longer ago by Renshaw et al., a couple papers here looking at cytologic features of H-cell in ThinPrep Pap tests noted that cases of H-cell that are more likely to be misinterpreted have some unifying features, including relative paucity of abnormal cells. So of note, in this particular study, ThinPrep slides that had fewer than 100 H-cell cells were actually found to be poor performers. And this is a little bit surprising to me, and I think it was perhaps also a little bit surprising to people to whom I posed a question in my Twitter poll yesterday, because this seems like quite a high number of cells for under 100 to be poor performers, and most people are guessing maybe fewer than 10 or fewer than 20 might be poor performing, but fewer than 100 in ThinPreps. And then actually he looked also at conventional slides, and the number was actually lower, that conventional PAPs that had fewer than 100 or fewer than 50 H-cell cells were actually found to be poor performers. Additionally, H-cell that showed kind of relatively small cell size or no large abnormal cells were found to be poor performers. H-cell that had kind of predominantly hypochromatic chromatin pattern was found to be poor performers, as opposed to kind of the more typical hyperchromatic chromatin, as well as H-cell cases that lacked any keratinizing dysplastic cells found to be poor performers. So the authors hypothesized that there would be these factors that may confound accurate interpretation, including a high number of L-cell cells in an H-cell PAP that could potentially exclude the diagnosis of there being an underlying H-cell in the background of L-cell. That the keratinized dysplastic cells could be difficult to interpret, as I think we probably all anecdotally know to be true, that keratinized dysplastic cells, among other features, tend to show kind of at baseline a little bit higher nuclear to cytoplasmic ratio, and it kind of starts to flirt with that diagnostic criteria for what constitutes H-cell, as well as dysplastic cells in clusters, that especially when you have kind of complex, potentially three-dimensional clusters of dysplastic cells, the nuclear to cytoplasmic ratio could become partly obscured and difficult to interpret. I say anecdotally speaking for myself, and I think in the experiences of others, as the authors had hypothesized. So here we have such a cluster that shows both keratinizing features and also kind of clusters of cells. And obviously here, I think that it's obvious that there's kind of some potential difficulties in rendering a great interpretation of that, especially if you're really trying to force yourself to pick one way or the other. So in the study itself, we looked at cells with dysplastic nuclei and an NC ratio greater than 0.5 as kind of a surrogate definition of H cell. And it's notable that some of the observers in the study actually identified 20 plus such cells and still ultimately classified the case as H cell. So this could lead one to conclude that were these authors seeing outright H cell cells and counting up H cell cells and then ultimately still classifying as L cell, or was this just kind of interpreted in a different way than the authors had really intended? And maybe this was not necessarily a perfect definition of H cell. Maybe it was not quite on the nose enough, and using kind of this euphemism for H cell as such might have confused things in terms of their actual enumerating of the morphologic features on slides. So ultimately, I think that probably for all of us, that the fact that the number of ASCH cells and H cell cells was associated with a correct interpretation is really not particularly surprising. But instead, it's more unexpected that really none of the other evaluated features correlated particularly significantly in terms of the actual morphology of the squamous cells themselves. There were some of the other features that correlated well, including like the presence of Candida, say. Everyone agreed that Candida was there, but for a lot of these other features, there was a lot of relative lack of correlation. So ultimately, the overall reproducibility for both the diagnoses and for each of these individual criteria was low in this study, and there was significant variation in the identification of specific sort of cytomorphologic features, and at least to some degree in determining the relevance of these features to the final diagnosis. So the authors raised the point that we may need to varying degrees, reevaluate and kind of reinforce with practitioners of cytology what are the criteria. So what are the features that make a case H cell, but perhaps also the criteria for the criteria, that in terms of the degree of disagreement as seen between these authors that are you know, to varying degrees experts, to what degree did they even necessarily agree on features that define dysplasia? To what degree do we all agree? To what are the features that necessarily define dysplasia? You know, above and beyond just kind of the semantics of it in terms of, you know, the words, everybody could probably list off features that really constitute dysplasia, but to really to what degree are these features kind of reproducible among us? So a study that was pointed out in the paper is this one by Bigris from 2011, Inter-Observer Concordance in the Assessment of Features Used for Diagnosis of SIL. And 17 observers looked at 150 different liquid-based PAP slides, and they kind of characterize the degree of inter-observer agreement in all of these different features, both cytoplasmic and nuclear. So here we have a figure from the article itself over on the right, and it kind of goes in a clock face configuration, creating kind of like a shell pattern. And there at about 1 o'clock, you have the feature that has the very most agreement among this panel of 17 observers, which included cytoplasmic staining, cytoplasmic anomalies, and then we kind of go all the way around to the other side of the clock face here, where we have kind of a collection of nuclear features, and these are what showed relatively poor reproducibility. So nuclear features in general had lower reproducibility than cytoplasmic features, and the feature that had the very least reproducibility of all of the features that were looked at in this paper was actually chromatin texture, which I think that probably all of us listening to this talk would have different opinions on chromatin texture. If we were shown a cell, we feel like we were able to describe it, but ultimately, at least in this particular panel of observers, it was really hard to get everyone to agree on, you know, what were the actual features of chromatin texture that we were seeing here. And it's a bit disconcerting, actually, then that nuclear features for which we place so much importance in terms of determining dysplasia and the degree of dysplasia are what actually have quite such poor reproducibility, at least in the context of this study. But then the authors of this paper actually then point out another article here. So this actually used kind of computer analytic techniques, and they looked at collections of cells, both normal cells, squamous cells from liquid-based preparations of cervical pap smears, normal cells, as well as squamous intraepithelial lesion. And it was found that L cell and H cell actually they had statistically more irregular nuclear membranes than nil. So in contrast, or kind of at least to some degree in contrast to the previous paper that I just sort of mentioned, they do have objectively more irregular nuclear membranes, and I think that we'd probably all agree with that, that's definitely one of these features. But also interestingly, in this paper that was actually doing measurements of the degree of nuclear irregularity, they didn't find statistically significant differences between L-sil versus the H-sil class of cells that they looked at, which at least kind of according to some of the real official Bethesda criteria, I think that it kind of at least vaguely implies that H-sil may have more irregular nuclear membranes, and I think that probably to some degree, at least anecdotally, we'd all agree that yeah, cases of H-sil we've seen seem to have more irregular nuclear membranes, but that wasn't demonstrated here. So the authors kind of go on to discuss this concept of intermediate categories. So notably, the observers weren't given an option between L-sil and H-sil for this study. And as previously discussed, for any number of these cases, it may have been the case in their routine practice that they may have used such a designation. Of course, also there's this whole concept of, long, outdated, very much outmoded term, moderate dysplasia, that's kind of fallen by the wayside in terms of its kind of objectively poor reproducibility from days gone by. That's part of the reason why we've gone to the two-tier system in the first place, is that we just couldn't agree with ourselves on this moderate dysplasia yet. Here we are looking at this exact same category again. So I think it's probably no surprise actually that in this potential gray zone area that things kind of continue to be gray. And in fact, kind of similarly dabbling in that gray zone area, ASCP in previous reproducibility studies, including the large Bethesda associated reproducibility studies, ASCP was one of these that showed kind of notoriously poor concordance even among expert observers. And other intermediate categories that were brought up in the context of this paper are, often fraught with controversy, but are variably used in clinical practice, and, to varying degree do have their practical uses. So things like ASCP plus L-sil. So you have atypical squamous cells. You can't rule out high grade at a background of L-sil. Is something that we have used, admittedly, to limited degree, but at times here, there are times that this seems appropriate, and to varying degrees, this, obviously this correlates with what we're seeing on the slide, but it can also correlate with what you see ultimately in follow-up biopsies and things like that. I think that can be kind of useful sometimes. Other intermediate categories include SIL-NOS, similarly controversial, and, perhaps also, this could feel a little bit wimpy to some people, that you have the squamous intraepithelial lesion for which you're unable to put your nickel down. But this too actually has at least some rare instances in which it can be used to some effect, especially in some notoriously challenging clinical scenarios such as that of atrophy, wherein you might have perhaps these keratinized cells or some such thing where in all reality you really truly can't tell, unable to make a distinction between varieties of squamous epithelial lesion. And then finally we have the most maligned category of all, L-sil-H, which has been proposed as kind of a third category of such, in between L-sil and H-sil. Kind of L-sil cannot rule out high grade, fraught with controversy as it were. This similarly denotes kind of an intermediate category, but again, these intermediate categories are kind of expressing varying degrees of uncertainty, and we're dabbling in this gray area here, so that gets really touchy. So as a further point of discussion, Cyto ultimately across the board has fairly low sensitivity for diagnosis of CIN2. It's kind of a well-known problem with Cyto in terms of screening, despite all of its the wonderful things that we all do in terms of our patient care. It has low sensitivity, approximately 60% for CIN2 for any number of different reasons, including obviously sampling. And ultimately, the positive predictive value for CIN2 plus is 78%. So that's really pretty good, and it's certainly better than the sensitivity. So then ultimately, in order to account for the relatively low sensitivity of Cyto, that's where we started to integrate some of these other measures, including like HPV molecular testing, which in contrast has really high sensitivity but relatively low specificity. And could other ancillary testing ultimately help augment the sensitivity and specificity of these respective tests that we routinely use in clinical practice? That's often been asked, and many papers have kind of explored that. For instance, the use of P16 or perhaps even P16Ki67 dual stain, or other ancillary tests, including stains from days gone by, and none of these have really quite panned out. And ultimately, a lot of this kind of or have necessarily panned out or have necessarily proven to be demonstrably extremely helpful in this particular domain. And largely, again, it has to do with kind of this gray area of the biology itself being problematic. So in cytology, we see frequent underclassification of high-grade lesions in many such studies such as this. And it begs the question that is this ultimately a failure to recognize features on the part of cytologists? Or is there actually kind of a bias, say, against overcalling high-grade, as it were, in order to prevent overtreatment? Are we actually kind of hedging towards not wanting to, give someone a diagnosis of high-grade, as it were, with what we kind of deem to be equivocal features still? But are we kind of over interpreting things as essentially equivocal or kind of undercalling in order to prevent an overtreatment? There's kind of some complex psychology there, and it plays into another concept that the authors call out, and that I feel like I've seen myself, at least anecdotally, that different philosophies exist in cytopathology versus calling up or calling down of various lesions like this, which definitely is complicated and again is sort of psychological. So ultimately, in studies like this and reproducibility studies in general, one of the main issues, or a major issue, is that biopsies are ultimately a rather imperfect gold standard. So colposcopic biopsies obviously are prone to sampling error, and ultimately colposcopic biopsy sensitivity is really only approximately 70% for high-grade lesions. That goes up a little bit with subsequent repeat biopsies. But ultimately, the sensitivity is not perfect for this, so it's hard to totally know if what we are seeing on colposcopic biopsy is really truly representative of what we see on the PAPs, whether or not another observer agrees that it was concordant in accordance with the kind of the methodology of this study. Even that is kind of subjective. Additionally, the actual interval between which we had the sampling of the PAP sampling and the colposcopic biopsy isn't specified. And while in all likelihood the amount of time wasn't tremendous, it's sort of the nature of cervical dysplasia that it can show, at least to varying degrees, interval resolution or progression. So it's not even totally possible to know if what we're seeing is kind of representative of the underlying pathology at the time of colposcopic or the PAP sampling. So ultimately, reproducibility of squamous dysplasia can be poor even on histology. So there's quite a bit of reproducibility issues, especially with regard to CIN2. And of course, they tried to circumvent that to some degree by using only cases that were kind of they were at a level of CIN3 dysplasia, which is kind of less problematic. And further, CIN2, it's kind of worth noting here, is kind of fundamentally not a biological entity, that instead this is an intermediate kind of non-biological entity that instead represents a mixture of biologically low-grade and high-grade lesions. So up to 50% of LSIL can actually show P16 positivity. So even P16 can't totally sort that out for us. And ultimately, it's kind of a complicated mixture of our we're using our morphologic skills to determine whether this is low-grade morphology on biopsy, but if you've got some number of these CIN2 lesions that are going to be low grade, then it's hard to even totally know if that, again, just kind of further casts some doubt on biopsies as a perfect gold standard. So in terms of these reproducibility studies, there are any number of different methodologies that you can use, and in the current studies, we actually had people looking at whole slides. And the issues with that is then, of course, people have to locate the features on the slide, and locating the features on the slide requires time and attention and effort, and of course, everybody is, they put in their time and their attention and effort, but ultimately you can just not find things, as evidenced by some of these cases that have relatively few HSIL cells, fewer than 100 on HSIL PAPs being poor performers. You kind of have to believe that probably to some degrees, especially in these cases as selected specifically today, that had a relatively few lesional cells, as it were people actually seeing the lesional cells in order to make an interpretation in the first place. And then other studies, such as kind of one of the big main Bethesda reproducibility studies, used actual single images that they were sending around. And these single images then, of course, highlight really specific cells for everybody to agree or disagree upon just on their respective morphologic merit, but then you lose the context of the rest of the slide. So sometimes having the context of the rest of the things that are going on the slide kind of changes the interpretation also, and that further complicates things. And of course, this particular study looked at challenging issues in separating low-grade and high-graded lesions, but they actually didn't look at a category of cases that I really find particularly challenging. I think most people find particularly challenging, which is that of dysplasia in the context of atrophy, which can really be kind of uniquely challenging in terms of determining, is there actually dysplasia present at all? And then if there is dysplasia, to what degree is the case dysplastic? I think that could be an area for further such study in terms of seeing the degree to which we all collectively agree on that. So in terms of the clinical significance of some of the things that we looked at today, of course, with the changing ASCP guidelines, one of the options now for screening is actually that of primary HPV testing alone. And what are some of the potential advantages of that? What are the disadvantages? So HPV testing alone has kind of the notable issue of being really highly sensitive because HPV infections are, unfortunately still relatively common particularly relative to the amount of CIN2+ that's out there. So with the relative sensitivity of HPV testing alone, I think that people are still fairly afraid, at least in the US, that this could lead to over-testing, that we'd actually be doing kind of too high of a number of colposcopies. So then there are strategies that are kind of being devised for how could we kind of augment that overly high sensitivity, including perhaps trending away from having cytology be something up front and instead doing reflex cytology, that we'd actually look at it at the back end, which would really kind of complicatedly impact workflows and be a drastic change. But then maybe you would have kind of a different combination of the respective sensitivity and specificities of each of those tests. And then additionally, in addition to expedited treatment guidelines being changed in kind of the most recent set of guidelines here for these patients with high grade with HPV-16 positive lesions, these patients that are 25 and older, non-pregnant, there's also more of a watch and wait approach for people with ASCS or LSIL, especially those without high-risk HPV. And as such, giving a person a diagnosis of LSIL in one of these complicated cases wherein it is diagnostically challenging could mean that obviously they're going to sit and watch and wait. And of course they'll follow up. Typically the follow-up for such a case would be in a year according to current guidelines. But then a year is enough time for things to grow and develop. So with this kind of shift in the guidelines to the real cutoff point being more between LSIL and HSIL, it's all the more important that we be able to kind of agree with ourselves and make this distinction reliably even in challenging cases. So that is all that I have as discussion points for you guys. And with that, I will take questions.
Thank you very much. That was very nice and very well done. We have a couple of questions. Some of them you have touched upon during your presentation, but I will read the questions so you can also, discuss it. So the first question was that, will there be significant change in interpretation of LSIL versus HSIL cytology with move towards the HPV testing, basically primary HPV and not much cytology? So that is one of the questions. So I'll let you kind of reiterate what you were saying.
Right, so it's hard to know, but it definitely does, especially with the change in the guidelines, it sort of changes the cutoff point, at least to a degree. And certainly also, as I kind of touched on, there is sort of half a thought theoretically that you could use cytology as reflex after HPV testing. I'm not quite sure I followed the question, but anyway.
I guess that was basically the fact that, if we move to the HPV primary screening, so how does it kind of affect our interpretations of the low SIL and high SIL, I guess, which is again the same thing. I mean, the primary HPV screening, as you said, it has its own controversy around it,
right.
And the reflex cytology after the HPV. Regardless of how much we try to kind of stay true to the cytologic features, after a patient has HPV-16 positivity, you're much more likely to figure, oh, this is a little bit irregular, or this is a little bit high NC ratio. So I I'm a little bit more, personally at least, I'm thinking that it may not be the true cytologic features that guide at that point.
I see. That's absolutely, at least anecdotally, really true. I think most of us who have that experience of being able to kind of quickly preview the HPV results before we actually, render a diagnosis on a case, you can't not feel a little biased by that. I think there was actually also a recent JASC article that came out that was saying something about kind of questioning the value of re-screening some of these cases that have HPV positivity but have already gotten a nil interpretation, in particular by a cytotechnologist. Exactly. There's kind of questionable value in that potentially, and I think that it is at least in part this that psychology of that can't not sneak into the back of your mind and kind of cause overinterpretation at times, especially in this context where, at least according to guidelines, these people are already going to be biopsied in spite of the issues that exist. Biopsy.
Right. Very good. The other question is a prominent heading that had to go for a rose, so I'm trying to read the question the right way. The question is the CAP PAP exercises sent to the institutions and discuss about cytoplasmic maturation to tell between L-cell and H-cell. What is your experience with that?
Cytoplasmic maturation. In terms of L-cell and so H-cell in particular has this tendency to be more immature in nature, particularly as it progresses through to even more unequivocal CIN3 or CIS, as it were, kind of the cytologic manifestations of CIS. You really get more immature appearing cytoplasm that can take on kind of a more net-like, almost pseudoglandular appearance even at times, though I hate to quite use that term, but it can kind of have almost a more frothy appearance. Certainly it starts to lose that appearance of having really well-defined squamous differentiation with kind of more polygonal cell borders and kind of that cytoplasmic density and kind of that turquoise color. So you lose a lot of those features, and that is definitely one of the problems, especially in terms of identifying H-cell in these groups of cells. As kind of previously stated, cytoplasmic features in general actually kind of proved to be more reproducible. So interestingly enough, maybe that is one of the ways that we could kind of help to further separate some of these things. But even that remains challenging, especially considering this really tried to simplify a lot of these respective categories in terms of making ASCH only atypical metaplastic cells and kind of defining H-cell a certain way, but ultimately there are a handful of different morphologic appearances of each. So it's definitely not without its challenges.
Right. I'll move on to the last question that I have right now, and then we'll go back to one that is in between. What is the ASCP guidelines for L-cell with a few cells suggestive of H-cell or ASCH, which is kind of, again, I think you mentioned some, but I guess maybe you want to reiterate. And again, the question is that how often we're going to use that L-cell cannot exclude H-cell diagnosis, and how does the ASCP guideline work around that, right?
So L-cell can't exclude H-cell is extremely controversial and is kind of officially not recommended. And part of the reason why that's officially not recommended is it's sort of, by and large, at least in terms of decisions that have been made at the level of kind of Bethesda committees, et cetera, it's not similar to ASCH plus L-cell. And that's kind of the preferred designation for an intermediate category as such, rather than trying to create an entire new category of L-cell-H. And the argument there is that that would kind of create a new kind of de facto 3-tier system that would be problematic in terms of its reproducibility, despite studies that have sort of shown that, well, each one of these different intermediate categories, both ASCH, L-cell, and L-cell-H, seem to have different features in terms of the overall HPV profile and in terms of the clinical follow-up. It still is, we have enough issues with reproducibility as is, so we kind of can't afford to throw anything else in the mix. And in terms of the follow-up per ASCP, I think that I think that, so ultimately the expedited guidelines are risk-based for people who have kind of the certain threshold of risk for CIN3 or CIN2 plus in particular on follow-up biopsy. And I think that HPV 16 plus ASCH, I think it is sort of another gray zone yet, but ultimately I think the colposcopic biopsy is the preferred follow-up for that as of this point. I think that it kind of starts to flirt with being in that category where you could kind of argue for expedited treatment as well. But I think that ultimately then colposcopy, and hopefully the colposcopy is then representative of whatever you're looking for.
Right. Very good. I now have a question for you, and that is that in your institution or in your neck of the wood, have you received any of these expedited treatments? Like you called something HSIL with the HPV-16 positivity, then the patient did not have a cold point between and got an excision?
That's an extremely interesting question, and unfortunately, that's a question that I don't know the answer to, but I should.
Right.
Because obviously that's
of
some real importance. But I think that probably it's certainly not anything that I have heard off the top of my head in terms of discussion, both with my cytopathology colleagues here, nor with some of the gyne folks. I think that is, despite it being kind of the preferred treatment, I think that's scary. And I think that it's scary, not without good reason. So kind of, at least in part, some of the aforementioned reasons we've been discussing, I think that probably that'll be, that's challenging.
No, I do think the same way, because I feel like that, oh, wow. I mean, again, we always go with the cytohistologic correlation. That's a big part of our quality metric in cytology, and especially with the GYN cytology, we have certain things that we have to abide by. And I wonder how would that work? So, you do a cytohistologic correlation and in your colposcopy, and if you don't have it, then, you kind of go back looking at your cytology case and you talk to your clinicians and you kind of go over the possible reasons for not seeing what you called HSIL in the pap in the biopsy that you received. But with the excision, that would be a little bit of a difference, because you always wonder, oh, maybe I didn't call it the right way. And that kind of opens up a bag of worms, in my opinion. But at the same time, I think a lot of things with the primary HPV screening and a lot of the new guidelines from ASCP, it's kind of, I think it's in the early stages, and I think for me at least, is a kind of murky water. So I kind of would like to see how it goes in the years to come, to see what's going on, because it changes a lot of our understanding of how we practice cytology in conjunction with the histology for the PAP cases. But I guess we'll see.
I can't agree more.
Very good, very good. I have one more question, and I think maybe Joanne can tell us more about that. And that is that, would you mind sharing a copy of your presentation? Joanne?
The presentation will be uploaded to YouTube. It is also, if you're wanting credits, it will be on the CytoCE Center, probably within about 24 to 48 hours.
So there we go.
Very good. I kind of thought I had the answer, but I didn't want to say it without Joanne blessing it. So thank you. Very good. I don't see any more new questions. Oh no, actually we do. We do have more questions. Sorry, I just stopped. I guess the question of the follow-up, which you kind of, I think you mentioned through. There is a thank you. And then the last one is that, is keratinizing dysplasia considered HSIL or can also be LSIL? So again, I think you went through that, but go ahead one more time.
It can be either. And although the findings in this current study didn't show that it made any particular difference, at least for this panel, in my anecdotal experience, and I believe in the experience of most people in cytology, that could be a difficult distinction, but either you can have keratinizing HSIL or you can have LSIL with keratinizing features. Either way, the distinction is definitely tough, because in these keratinizing lesions, you do have a lower NC ratio. So you could be argued, theoretically, that you could kind of change that threshold and lower the threshold for, or rather raise the threshold for what NC ratio constitutes definitive high-grade dysplasia, but that's kind of complex. And ultimately that complexity and that just kind of that, ultimately you just kind of have to make your own decision as to what is this too much? But it can be either, so, and that's tough.
And you can pray to God that you find some cells that look like typical HSIL in the background, so then you can put your mind at ease. That's what I'll try to do, because it is very difficult. And I always there used to be more of the, not more, but there was this category of keratinizing dysplasia that you cannot grade, which is the current kind of SIL cannot grade, kind of goes into that, which is not necessarily very much encouraged to use, because we want to be able to kind of definitively say yes or no to HSIL or not. But it is something that I spend a lot of times looking at those cases and trying to convince myself where I would want to fall on that. So
quite
it
challenging. Context does
Right.
really help, and that's part of
Right.
the challenge today. Was I showed you just that still image.
Right.
That is an extremely challenging still image, as evidenced by kind of our informal Twitter poll, as it were, where the responders were 50-50 on their interpretation, or very nearly so.
That is very true. Okay, I guess we have another thank you, and I do not necessarily see any. Oh, we have international audience too, so that's great. But we don't have anything else. I think we should be good to call it a day, unless there is more questions in the next 2-3 minutes that I would read. I don't see anything right now. But well, while we're waiting for the top of the hour, let's just say thank you very much. This was a very nice presentation. It was very much, you know, invoking a lot of thoughts in everybody's head, and we all deal with these things every day, day in, day out. When you get your tray of PAPs, you know that you're going to go through some of these questions on a day-to-day basis. But it's good to keep talking about it, to learn more about it, and hopefully we can make the best out of it.
Absolutely. I'm just proud as can be to be part of a group like this that's doing so much to do best by their patients and make accurate interpretations and diagnoses. So
exactly. I guess we'll say goodbye, and till the next eJournal presentation in May. Hopefully we'll see the entire audience again, and we'll take it from there. Thank you very much. Have a good day.
All right. Bye for now.